So welcome again, everybody. My name is Sara Moscatelli. I'm currently the coordinator of the PINK International Young Academy of Cardiology. The PINK IYAC is a subgroup of the IYAC, International Young Academy of Cardiologists, and we have the pleasure also to have Professor Tuğba Kemaloglu here with us, that is the founder of this great activity. In particular, PINK IYAC has the main aim to help women in their career, and so help women in developing their dreams and ideas. And this mini course is exactly this. We are started from an idea from Dr. Stefania Di Fusco that I have the pleasure to introduce, and we are now here realizing this mini course. So Dr. Stefania, she's a brilliant cardiologist from Italy. She's currently working in Rome in San Neri Filippo Hospital. She's an expert of heart failure, and she's also the chairperson of the AMCO group. It's an Italian association of young cardiologists. Sorry, Stefania, if I haven't said it correctly. So I have a great pleasure to introduce her and to let her speak about this new adventure.
Thank you very much, Sara. I am glad to be here today together with my colleagues with whom I organized this event, so endorsed by the Cardiovascular Academy Society and conceived and created by PINK IYAC. I thank Sara Moscatelli for embracing my proposal and helping to make it a reality, together with the valuable support of Tuğba Kemaloglu Oz and all the amazing PINK IYAC ladies. We decided to organize. Please mute.
Ciao Matti. Un bacio, ciao ciao.
Please mute the phone.
1 second, some technical issues. So please, as I said at the beginning, it's very important your support that you mute your audio, because there's gonna be a lot. So if we want that this gonna work, we need to. Okay, please, Stefania. Now, Stefania, just a second. I need to reactivate your audio.
So, we decided to organize this mini course to respond to an unmet need. As physicians, we know that statistic knowledge is essential in being able to interpret, critical appraise, and implement scientific literature. With this webinar, we aim to provide basic statistic knowledge so that you will have a better understanding of the method used in clinical studies. This is the first of a number of webinars on medical statistics. Each webinar will have 2 presentations that are followed by a discussion in which esteemed colleagues will contribute to the discussion. So they will ask her the questions and read questions from the chat. So in the interest of time, please, all the attendees should mute their microphone and only ask the questions in the chat. Of note, we will answer all the questions we have time for. Now, I am delighted to co-chair this event with Biljana Parapid. I am sure that it will be a very interesting experience for all of us. My distinct pleasure to present Biljana. She is Assistant Professor, Department of Internal Medicine, Cardiology School of Medicine, University of Belgrade, Honorary Proctor Harvey Teaching Professor, Leadership Council Member, and American College of Cardiology Week Section Chair. Now I will pass the microphone to her.
Thank you so much, Stefania. We opted to go with first name basis, so I'm dropping Dottoressa Di Fusco. Otherwise, it's a great pleasure and an immense privilege to be with you here today. And I would especially like to thank PINK IYAC for inviting me to be part of their junior mid-career think tank. I try to stay away from ageism in my proposal. So without further ado, and I would just like to introduce our first speaker of the day. We'll have plenty of time to discuss our preferences and our topics, and how this endeavor is also interesting for all of us and in different ways during discussion. But right now, without further ado, I would like to introduce Dr. Monica Verdoia, who is an MD PhD interventional cardiologist from Ospedale degli Infermi in Biella, Italy, which is also part of Università del Piemonte Orientale, who will talk about study designs and types of evidence from the standpoint of epidemiological data analysis. Why is it a topic that is so close to my heart? I happen to be the third generation of investigators for the 7-country study, and for all those who don't know, actually, it's the 7-country study that linked diet to coronary heart disease and cancer and postulated the concept of what we know today, the Mediterranean diet. So, Dottoressa Verdoia, grazie mille. We're waiting for you.
So thank you very much. Good afternoon to everybody. It is my pleasure to be here today and to share with you my presentation. I first want to thank the Pink IYAC and the course director, Dr. Di Fusco, for the invitation. So when we think about medical studies, the first thing that comes to our mind is that they are boring, they are complex, but they are necessary. And why are they necessary? Well, they are necessary because it is the only way we have to answer a question, a medical question. And this question is answered by epidemiology. The question is who gets a disease and why? So epidemiology is the study of the determinants, distribution, and frequency of a disease. It means we can compare sick people and healthy people to define who gets a disease and how to treat it. And also we can compare exposed people and non-exposed people to verify the effect of a risk or a preventive factor on the development of the disease. So epidemiology can answer several questions. Why? So the cause or etiology of a disease. What and when? Then it is to describe the characteristics of the disease. How? That is the mode of transmission. And where? That is to identify the geographic patterns. So we may say we are studying the interaction between a patient, the host, and a particular factor we want to study that can be either a risk or a preventive factor or even a treatment measure. But this relationship is not direct. There is a third party that comes in the interaction, that is the environment, that can interact even with the host and with the agent, creating a triangle and modifying each of the relationships and making something that can be very difficult to assess. So the purpose of epidemiology is to define measures for the prevention and treatment of a disease in the whole population by analyzing a group of it, of the same population. And then we can perform a study for two different aims, either etiology or prognosis. Of etiology, we have said it is the cause of a disease. But when we speak about prognosis, we can have two different endpoints, mortality, the most common one, and morbidity. And in cardiovascular disease, morbidity is generally defined as MACE, major cardiovascular events, which are a composite of death, myocardial infarction, stroke, and some additional endpoints that can be defined every time differently. And the measures we have are the prevalence and the incidence. Which is the difference? The prevalence is the proportion of a population who has a disease. And this is generally defined as a percentage. It is like to make a picture of the population and count the number of affected subjects. Instead, the incidence is the proportion of a population who develops a disease in a particular period of time. It means that we are making a video and we start in a in a certain period of time, and then we wait for the development of the disease. So the difference between the two is that we have time. We must also distinguish between two types of epidemiology. Descriptive epidemiology is the one in which the investigators simply observe their studies and the reality and describe. Instead, in analytic epidemiology, the investigators go more in deep and they try to verify an hypothesis by evaluating and trying to verify a certain hypothesis by making an intervention. In my presentation today, I will focus only on observational studies that are the pure epidemiological studies, we can say. But they are also the ones with a little lower strength that is called evidence, as compared to randomized clinical trials that are the classic interventional trials. And this is because randomized clinical trials have an increased evidence when they reach a certain conclusion, because they have a larger sample size and they mix up the population, allowing to control for variability that is called confounding factors. But we must also say that randomized clinical trials select the population, and so they tend to exclude generally very low or very high risk populations. And also in certain cases, they may not be feasible because it may be not ethical or not practical to treat, to administer, or to deny a certain treatment in the control population. Instead, when we speak about epidemiological studies, these are real-life studies, so the population is generally closer to daily clinical practice, but they experience an increased risk of what is called bias. And the bias means that we go wrong in our conclusions because we are misled in the selection of the population, in the identification of the disease, or by the role of modifying confounding factors. And indeed, epidemiological studies can have a great clinical significance. And despite we have said that interventional trials are the one with the greatest validity, but also with highest costs, we can reach in certain cases the same or acceptable conclusions by other kind of epidemiological studies, and then it is important to know them. For example, cross-sectional studies are studies in which both exposure status and disease status are assessed at one point in time. It means like having a rainbow cake and cutting a slice. All the colors are already there. You just have to sort them and count. So you can get the number of affected subjects and unaffected subjects, exposed and not exposed, that can be represented in a 2x2 table. And what we can calculate in this case is a rate, and it is what we have defined as prevalence. The advantage is that we already have all the data at the beginning. We don't have to wait. So they are quick and less costly, but they may be inadequate for rare disease, because when I take the picture of my population, I may not have enough cases. And also, if the disease has some remissions, I can misclassify the patients because they may seem healthy when I evaluate them. And finally, I am not able to define whether the cause came before the disease, so I cannot be sure about the temporal sequence and then causality. A little better is with case control studies. in these studies, we start by sorting our population in affected and not affected with the disease. It is like sorting the red and the blue fish, and then going as a fisher to pick up all the subjects that are exposed to a factor we want to evaluate, that is analyzed at one point in time. So the advantage is, again, that we are quite quick because we don't have to wait for a follow-up. And we are even in advantage when we want to evaluate rare disease or disease that take long for developing, because at the beginning of the study, we already have all the cases and we are sure to have enough. In addition, we can question our population for multiple agents, for example, multiple risk factors at the same time. The disadvantage, however, is that I don't have, again, a temporal sequence, and also I cannot calculate the incidence, but also not the prevalence, because in this case, I don't have a whole population to compare, but I have only a sample of selected cases, and so I cannot calculate a proportion. And finally, another problem can be the recall bias, because when I interrogate my cases and control, they can not remind properly about exposure, and so I can misclassify them. The measure of association in a case control study is called the odds ratio. It is a ratio between odds, where odds is the number of events on the population at risk, that is the exposed population. If I get a result below 1, I have a protective factor. Above 1, I have a risk factor. And if it is 1, then I have no association of the factor I am analyzing. In addition, cases and control may differ for their characteristics. And then I can try to control for this kind of difference that can create a bias, a confounding bias, by matching, that is pairing to each case a control that is similar for age, sex, or other characteristics I want to analyze. And also I can do a group matching if I try to keep the rate of a certain characteristics to a certain threshold, both in the cases and in the controls. It is vital, however, that I select well my population and my cases that must be representative of the population I want to treat and analyze. Also because the controls come from the same population, and they are not affected by the disease, but they may be, in any case, exposed to the agent I am analyzing. Finally, the last type of epidemiological study is the cohort study. Cohort means a group of persons proceeding together in time. It means that we have a population, we identify exposed and not exposed, and then we wait for the disease to develop. In this case, we start from the present and we go to future, and it is a prospective cohort study. However, this can be very risky because it takes a lot of time, a lot of costs, and I may also lose to follow up some of the participants. To avoid this, I can do a backward strategy that is called a retrospective cohort study. In this case, I already have the subjects developing the disease, and then I go back in the past to identify the population, how it was at the beginning before the development of the disease. But it is vital in any case that I have a follow-up period for the whole cohort of patients, because otherwise I am picking up just a picture and I am falling in a cross-sectional study. In this case, since I have time, I can evaluate the incidence. and the incidence in exposed and in unexposed creates the measure of the relative risk, that is the result generally given for cohort studies. So to conclude, we must say that epidemiological studies have received in the last years much more attention than it was in the past. In the past, as we can see, they were only used at the beginning of the development of a certain treatment or a certain type of analysis. And nowadays we use them in different time points. Why? Well, for sure, epidemiological studies are the best ones in the initial phase, when we want to describe the population, the disease, and define unmet needs. And this allows to properly design randomized clinical trials and get the best and most powerful evidence in our conclusions. But then in the mature phase, in the last phase, we have to go back to real life and verify if our conclusions are supported by effectiveness, and also for checking for safety and potentially adverse reactions. And this is the strategy suggested by the EMA when we want to perform a registry. We need to identify an unmet need. We need to check for existing registries in order to avoid overlapping. And finally, we have to plan our study. So before starting, we have already done a lot of job and studied a lot. And these are my suggestions. Thank you very much for the attention.
Thank you, Monica, very much for your brilliant speech. I would like to remind the audience that if they have any questions, please, they may use the chat. And at the end of the second presentation, we will have some time dedicated to questions and answers. Now, I am very glad to introduce Dr. Aisha Kader, who will give a basic primer on randomized controlled trials. Aisha is a cardiologist with an interest in interventional cardiology at the Ibrahim Cardiac Hospital and Research Institute, Dhaka, in Bangladesh. Her research interests are focused on coronary syndrome, coronary intervention, outcomes, and sex disparities in cardiovascular disease. Aisha is currently undertaking a part-time master in clinical trials at the University of Oxford. So I am very happy that she is with us today. And there, Aisha, we are all ears and we look forward to your speech. Please.
Thank you. Thank you so much, Stefania, for that very kind introduction. Can I confirm that my slides are visible?
Yes, they are.
Yeah, fantastic. So good morning, good afternoon, and good evening to all of you from wherever you have connected. And thank you so much once again to the Pink IYAC for the opportunity to speak today. I will deliver a very basic primer on randomized controlled trials, and I'll basically be speaking on much of the concepts that I have acquired over the last year as an MSc student. So the outline of my talk would focus on RCTs in the hierarchy of evidence. Monica has already spoken of the hierarchy of evidence, and we'll see where RCTs fall into that. What constitutes a good research question, the key concepts of randomization, why it's done, its principles. We'll talk a bit about blinding, and finally close with different trial designs. So if we go back to the hierarchy of evidence, there are some research designs are indeed more powerful than others in their ability to answer research questions. There's observational data that you just heard about, and indeed randomized controlled trials, as well as systematic reviews and meta-analysis from which they are derived, provide the most reliable evidence, or indeed the gold standard, on the effectiveness of interventions. And this is purely because of the processes used during the conduct of an RCT to minimize the risk of bias and other confounding factors that might influence the results. And that's what we'll talk about today. But before that, let's just have a brief outlook at what might constitute research phases. And this is predominantly in terms of drug development, where RCTs play a major role. Before we come to a randomized phase, there are preclinical studies that look at the safety of a drug. Phase 1 are small numbers of first-in-man studies that are usually randomized, but not always, looking at safety, pharmacokinetics, and dynamics. And phase 2 drugs are also often, but not always, randomized. They look at potential drug-drug interactions. Phase 3, and this is really the main focus of the majority of RCTs that we as clinicians perform, are usually much larger, and they're always randomized. And they look at clinical efficacy and safety, particularly in terms of licensing decisions as well. And phase 4, as we know, are post-marketing surveillance. So what is a randomized control trial? RCTs, as I said, are regarded as the most scientifically rigorous method of hypothesis testing available in epidemiology and medicine. And a widely accepted definition of an RCT is a clinical epidemiological experiment in which subjects are randomly allocated into groups, and we'll talk about that, usually called test and control groups, to receive or not to receive either preventive or therapeutic procedure or an intervention. And the results, or the outcomes as we would call it, are assessed by a comparison of the rates of disease, death, recovery, or any other appropriate outcomes in the study groups. So if we were to break down these 3 words, randomized would constitute an equal chance of being allocated to either arm, either the intervention or the control. And this is important to eliminate bias in selection, and it also balances all known as well as unknown confounders, which we can't expect from an observational trial. Controlled is where the new intervention is compared to a control, and the control can be an active control, it can be a placebo, it could be sham. And this ensures that both groups are identical except for the intervention that we're testing. And the trial, of course, then constitutes an experimental intervention. So what are the key elements of an RCT research question? We need to have a focused and clearly defined research criteria. And this is often referred to as the PICO criteria, which I'll talk about a little more in detail in a bit. A research question has to be based on clinical equipoise, that is based on the uncertainty principle. The treatment effect must be clinically worthwhile and improve current practice. And the question has to be answered reliably and safely. And this is where ethics comes into play. A little bit more about the uncertainty principle, and this is the crucial and one of the central tenets of an RCT. It means that there is a genuine uncertainty among physicians about the benefit of one treatment compared to the other. You have to be unsure of its benefit, because if you're absolutely sure, then you will not be randomizing patients. Now let's talk a bit about hypothesis testing. So from the point of view of determining the sample size, this is to be able to reliably reject that there is no treatment effect. And this is the entire concept of what hypothesis testing is. The central tenet of that is, then again, the null hypothesis. And this means that there is no difference between 2 treatment groups. It means that the 2 treatments that we're testing, the intervention and the control, are identical in their effect in the outcome of interest. And it's essentially a statement of equality. The opposite of this is the alternative hypothesis. And this means that there is a difference between the 2 treatment groups being tested. That is, that there is an estimated effect of the intervention that you're testing. What is statistical power? It is the probability that the statistical test rejects the null hypothesis when the specific alternative hypothesis is true. In other words, it is being able to detect a treatment effect. And this null hypothesis is rejected if the data derived from the study, that is your study results, are not consistent with it. And this is then measured by the p-value, which essentially measures the probability of seeing the data or some extreme of it if the null hypothesis were true. And the p-value is generally set at 0.05. So based on what we just learned, the smaller the p-value, the lesser the probability that the null hypothesis is true and that the alternative hypothesis is. So let's just have a look at some of the possible outcomes of trials in terms of results. So when an intervention has a real effect, and this is observed in the trial results, that means that there's evidence against the null hypothesis, this constitutes a true result, and this is a true positive. When there is no real effect, and your study finds that there is no effect observed in the result as well, then this is a true negative, and that is also a true result. So these are not errors, these are actual results. But say there is a real effect of this particular intervention, but your study does not find it in its effect. That then is a false negative, which constitutes a type 2 error. And if there is really no effect of the drug, but the study finds that there is a false effect, that would be a false positive, and that is a type 1 error. So now let's talk about the research question and in terms of the criteria. We did speak of the PICO criteria, so that is population, intervention, comparator, and outcome, with, of course, a time to follow up at the end. So if I were making up a trial about a new treatment that would reduce mortality in MI, so to speak, my population would be all patients presenting with a myocardial infarction. So that would be the trial population. The intervention here would be this new drug that I'm trying to test that would reduce mortality. And in fact, in trials, an intervention could be a drug, it could be a vaccine, it could be a new device, a surgery, and
Sorry, Aisha, can you reactivate your audio?
yes, I just did.
Thank you.
All right, sorry about that. So I was saying that the intervention could be a drug, a vaccine, surgery, or even behavioral. The comparator then is the control against which you would compare, and this could be a placebo, it could be the standard of care, it could be a sham procedure in terms of surgical or procedural trials. And finally, the outcomes or the endpoints that you would need to predefine. This can be primary, secondary, tertiary, it can be a surrogate, and particularly relevant to cardiovascular trials is a composite outcome. And these patients will be followed up over time. So a little bit more about the outcomes. A primary outcome is the main outcome for which the trial is powered and randomized. And it is the outcome that drives how one defines an improvement due to the intervention. Secondary outcomes, there are also predefined and limited set of these, which are endpoints for treatment efficacy. However, they're often not powered for decision-making, and they detect less frequent findings than the primary outcome or event. A surrogate outcome is an indirect measurement of the outcome, and this is reliable and valid. And for example, these are what constitutes perhaps lab tests like an NT-proBNP in a heart failure study. And a composite is an addition, 2 or more events merged into one endpoint. And these are very popular in cardiovascular trials where we have 3-point MACE, that is major adverse cardiac events constituting cardiovascular death, MI, revascularization, and 4-point MACEs that would also include stroke. So let's look at applying the PICO criteria in practice. So this was a publication that came out last year of the Soloist WHF trial, which looked at the effect of sotagliflozin, which is the new drug, in patients with diabetes and recently worsening heart failure. If we were to apply the PICO criteria here, the P or the population are those patients with type 2 diabetes who were recently hospitalized with worsening heart failure. The intervention here is the new drug that's being tested, that is sotagliflozin, and they were tested against a control, which was placebo. And the outcome or the primary endpoint was the total number of deaths from cardiovascular causes, hospitalizations, and urgent visits for heart failure. That was also very well defined in the trial publication. So why and how do we do randomization? Randomization essentially is a process by which allocation of subjects to treatment groups is left to chance or randomness. Why do we need to do it? Once we've defined the research question and we've gotten the eligible participants, we then need to randomize them. It is to eliminate bias in treatment assignment. It also facilitates blinding of treatment allocation once the allocation has been given, and it permits the use of a probability theory to express a likelihood that any difference in outcome is due to chance. So essentially, randomization would mean that all baseline characteristics are balanced, and the only difference between the two groups is the intervention that you're testing. And as is visible again in this baseline characteristic table of the Soloist study, all of them are essentially very well and equally balanced. So what are the principles of randomization? They're mainly based on 2, and one of them is the generation of an unpredictable allocation sequence. And this means that the investigator cannot predict the assignment in advance, because the ability to predict that could bias the choice of the next patient to be randomized. And once that has been done, the allocation concealment is also important in that you have to prevent foreknowledge of the treatment assignment. This is not the same as blinding, which we'll talk about later. And indeed, allocation concealment is now less of a problem with computer-based centralized randomization methods than the sealed opaque envelopes that used to happen in days gone by. What about now the methods of randomization? We have simple randomization, which is like coin tossing. So there's no connection to treatment allocations. And this is simple and easy to do, but it can lead to a relevant imbalance between groups in numbers or key patient factors because you're not controlling them for the other baseline factors. Restricted or block randomization is when the allocation sequence is broken up into blocks with equal numbers of each allocation within each block, and the order of the treatment with each block is then random. So there is a risk of predictability when the blocks are small. So we come to the concept then of a random permuted block, where these block sizes itself may vary to avoid predictability, because as we mentioned, one of the essential components of good randomization is an unpredictable allocation sequence. Stratified randomization aims to ensure balance for key patient factors across treatment groups, especially in case of certain factors that you are particularly keen to ensure are balanced. As you can see in this example, they've stratified for both sex and age. So there are equal numbers of men, equal divisions of the men and women within the study group, as well as equal divisions of young and old patients within the study group. Minimization is a dynamic and sophisticated method where randomization lists are not really prepared in advance here, but instead it progresses as the trial progresses, and a computerized algorithm determines in which treatment assignment would achieve the better overall balance across multiple patient characteristics. Sometimes trials use an unequal randomization, that is not 1:1, but instead 2:1 or 3:2. And this is done in order to increase information on a new treatment. If it's a very novel treatment and you want more patients randomized to the particular treatment and not controlled, then you would do something like that. And also to stimulate a greater enthusiasm by both the patients as well as the investigators. And an example of that was the Simplicity HDN3, which was a renal denervation trial where they randomized 2:1 in order to make sure that more patients were given the procedure and not the sham. And finally, we have cluster randomization, which is performed when larger groups are randomized instead of individual patients. And this is generally done in case of health system interventions. So now that we've randomized and we've allocated the treatment, we come to blinding. And this essentially means that both the patients and those responsible for their treatment and follow-up evaluation do not know which randomized treatment they're assigned. So we have patients and we have the person assigning the treatment or the investigator and the outcomes assessors. So why do we need blinding? It is in order to reduce reporting bias, to improve compliance and retention in a trial, because if a patient knows that he's on the treatment, he may, especially in case of patient-reported outcomes, he or she might report a positive outcome, knowing that she is on the treatment. But if it were on a placebo, that might alternately cause the patient to reduce adherence or non-compliance or even lose interest in retaining themselves in the trial. And of course, finally, it also ensures an unbiased outcomes assessment. How do we do blinding? We could use placebo, a double dummy technique, which is 2 types of different colored tablets, and a sham surgery or an intervention that is particularly relevant to surgical trials. So as I mentioned, we have these 3 groups. So if none of them are blinded, it is an open label trial. If the patient is blinded, it is a single blinded trial. If the investigator or the person administering the treatment and the patient is blinded, it is a double blind trial. And if the outcome assessor is also blinded, it is a triple blind trial. Let's look at an example of these things in practice in the Augustus trial, which was a 2x2 factorial design trial that randomized patients to a NOAC, that is apixaban and a vitamin K antagonist, as well as aspirin and placebos. So there were 2 different randomizations among patients with ACS or PCI requiring already on a P2Y12 inhibitor. So the first phase was an open label trial. That means both the patient as well as the investigator knew what anticoagulant they were on. And this is presumably because a warfarin would require therapeutic INR and repeated blood testing. And the patient who was given that would essentially know that they were going to have that being tested. And it doesn't make sense really to put a patient on a NOAC on repeated sham procedures of having to draw bloods for these tests, presumably. The second randomization was between aspirin and placebo. This is a straightforward thing where it would just constitute giving the same colored medication. So that was then a double blind trial, a double blind blinding, sorry. And finally, now let's look at the different trial designs. Most RCTs are parallel arm trials, and that's where individuals are then randomized 1:1 to either treatment or control. This can also be 2:1, as we mentioned. And it's the simplest design, and it's also constitutes a straightforward analysis and interpretation. Parallel arms can also have more than 2 arms, and that is to test different treatments or to test different doses, and it allows the comparison of one arm with the other. Factorial trials are more complex and they allow 2 or more simultaneous randomizations. We just saw one in the Augustus trial example, and this allows 2 or more hypotheses to be tested independently of each other. So it's a very efficient trial design, efficient knowledge gain rather, where you get essentially 2 trials for the price of 1. Crossover trials are when the patients are randomized and given a treatment and control. This is followed then by a washout period where this particular treatment and control is entirely washed out. And then these same patients are then randomized to the opposite of what they were initially randomized to. So each participant here acts as their own control. And this is best suited for stable conditions like blood pressure medications, where the treatment effect is reversible and short-lived. But these crossover trials come with the disadvantage of having a dropout as well as carryover effects in the event that the washout period is not long enough. Just a bit about adaptive trials and platform trials. Adaptive trials modify the trial design based on interim data, and they are reported to reduce resource use, decrease time to completion because the trial becomes efficient based on the data that is interimly provided and improves chances of relevant trial results. Platform trials, they allow multiple interventions to be tested against a shared control group, and the protocol design is designed to allow interventions to be added and removed easily without requiring new trials to be set up. And the best example of an adaptive platform trial is what we know as the recovery trial, which is the largest COVID-19 drug trial in hospitalized patients in the world. Lastly, cluster randomized trials are performed when larger groups are randomized as opposed to individuals. This is generally done to evaluate health systems interventions and also to avoid treatment group contamination. This is also accompanied by administrative convenience, particularly in lower resource settings. So finally, putting it all together, and this picture, as I will show you, is derived from a very interesting 4-part series on medical statistics by Stuart Pocock and colleagues. We talked about the research question and the choice of patients, that is the PICO criteria. We then talked about the choice of the intervention and treatments, having to specify the treatment regimens and also the placebo and the sham as the control. We then talked about choice of outcomes, defining the primary efficacy endpoint and selecting the components of it, as well as listing the secondary endpoints. We then, after the research question was identified, we talked about the principles of randomization, why it needs to be done, the methods it can be done. And once patients were randomized, we talked about the importance of blinding and its practical applications. And finally, trial design, as well as effect size and power. And further statistics will then be covered in the upcoming webinars of this course. This is the recommended reading. As I said, I highly recommend reading all 4 parts of the 4 papers in IYAC by Stuart Pocock. It's called Statistics for Clinical Trials. And with that, I'll stop and thank you so much for your attention.
I'm activating the audio of the discussants and of the moderators.
I think that Stefania is not unmuted still, so she cannot.
Okay, now I am. So thank you very much, Aisha, for your excellent speech as expected. We have learned a general overview of 2 relevant topics in medical statistics. Now the discussion is open, and we have 2 esteemed colleagues as a discussant. We will start. Please, Vijana.
Okay, it's a great pleasure and a privilege to introduce Dr. Filippo Zilio. As you have noticed, the PINK IYAC tried to enforce the concept that he for she and she for she normally work together. So we made sure that even if our speakers were prominent WIC or WIC in the making, that are going to be trailblazers, we just want to show that we normally function with not just WIC in our everyday work settings. So I would just like to welcome Dr. Zilio again. He's an interventional cardiology who is who graduated from University of Padua, where he got his cardiology diploma in 2015. But from 2016, Veneto region lost him to Alto Adige. So he is in Trento, where he practices as an interventional cardiologist. And he is also co-chair of the EMCO Young Cardiologists Group from 2019 to 2021. So Dr. Tilio, before actually we have your question for the Teresa Verdoia, I would just like to invite her because I know that she prepared a bunch of amazing that we kept for discussion. Dr. Cadero already showed hers and part of her talk, but I would like to invite Monica to show that portion of her PPTX that we kept for Save the Best for last.
Good evening to everybody. First of all, I want to thank Pink IYAC and Dr. Stefania Di Fusco as coordinator for involving me in this very interesting webinar. And compliments to Dr. Verdoia and Dr. Kader for their presentations that were complete and clear. And so, a question for Dr. Verdoia. Can you please cite some examples of these different types of interventional, observational studies you talk about?
Thank you very much. Thank you for the question. I will show, as invited, my additional slides. And so I go back here. And well, I can tell you some examples. For example, I thought that we can have the same, try to assess the same aim with different kind of studies. When we perform the same epidemiological study, that is a study to evaluate the role of cardiovascular risk factors in a certain population, we can get very different results depending on the design of our study. This is an example of a cross-sectional study. The most common cross-sectional studies are the ones that are performed with health questionnaires. For example, we administer this questionnaire to the outpatient visit to a high-risk population, as in this study that was conducted among patients with diabetes. And what we get is the prevalence of cardiovascular disease. We can know how many diabetic patients have also cardiovascular disease, but that's it. Instead, we can also do another kind of study. We can try to perform a case control study. That is, we can evaluate the weight of every different cardiovascular risk factor on the risk of developing coronary artery disease. This is the example of the InterHeart case control study. That is a very big study that was performed in low-risk countries and mainly started in India. And it showed the weight of different cardiovascular risk factors on the role on the occurrence of the first myocardial infarction. As I have shown you before, the measure of association in this case is the odds ratio. And we can see we have some protective factors with an odds ratio below 1 and some increased risk factors with an odds ratio above 1. And it is not surprising because risk factors are smoking, diabetes, hypertension, obesity, and protective factors are fruits and vegetables, exercise, and moderate alcohol intake. So these are things we already know, but as you can see, these are confirmed in also in low cardiovascular risk countries. finally, we have cohort studies, and well, I could not omit the Framingham cohort study that is the father of most of cardiovascular cohorts. It is the cohort is the whole population of a city that is Framingham, that is a small city in the US. And okay, all the population of this small town was followed up for more than 70 years. And well, then they derived some sub-cohorts to evaluate specific endpoints. And what they could get was the role of different cardiovascular risk factors on the risk, the relative risk of developing cardiovascular disease. And thanks to this, they could create a risk score that in this case allowed to predict the risk for an individual subject and not for the whole population as in case control studies. So this is even more informative when we want to assess the weight of a single cardiovascular risk factor. These are mostly the three types of epidemiological studies I have addressed.
Thank you very much, Monica.
Before we shift to Dr. Kader's talk, and I give it over to my Madam Co-Chair, Dr. Di Fusco, we have been getting lots of questions for folks who actually ask questions for our webinars 2, 3, and 4. And as if I see things developing well, we might even have a joint number 5 with all the discussants from all the previous 4 to answer all the questions folks might devise until then. So we will not be quoting these questions. We will just address those that were pertinent to the talks of our 2 speakers of the day. And also, since lots of folks in the audience were asking for slides, we have planned in general to make them available in PDF form on the IYAC website. So just be patient with us a bit, and we're all a bunch of volunteers here, and Dr. Kemaloglu Oz is also handling a huge portion of the work dedicated to making things available on the website, and we're all also working with our patients every day. So let's just have some more patience with us, and for sure you'll have all the material in the weeks to come. So we have one last question for Monica, and that is, can we interpret, oops, it's gone. So can we interpret OR as a risk factor, or is RR or HR more related to risk?
Well, let's distinguish. The odds ratio, as I said, it can be interpreted as a risk. It means that you have the weight of a risk factor, but it is not applicable to a single individual. It means I cannot say this subject has 30% more risk of having a certain disease if I have an odds ratio of 3. But instead, I can calculate this when I have the relative risk or the hazard ratio that instead is calculated for randomized trials. Both the relative risk and the hazard ratio implicate that we have a follow-up in time. And so we can calculate the incidence of a certain disease, which is not calculated on the odds ratio. You can measure the strength of the association, but not the exact weight.
Thank you very much, Monica, for your clear explanation. Now we have our second discussant, Dr. Sotiris Nedios. He is an electrophysiologist and researcher. He trained in advanced arrhythmias in Maastricht and Boston and graduated as valedictorian from the Global Clinical Scholars Research Training program of Harvard. Sotiris is a statistic enthusiast, associate professor at the Heart Center of Leipzig. So please, Sotiris, you have the microphone and you can ask your question to our speakers.
Thank you, Stefania. It's my pleasure and my privilege to join you today. And congratulations to Pink IYAC for this achievement, and looking forward to further webinars and more in-depth statistics. Congratulations to Monica Verdi as well for the nice presentation and the awesome presentation of Aisa Kader for randomized trials. It makes it seem so easy. But I would wonder, you know, what are the challenges that one may encounter in trial design or in the subsequent analysis when you try to pull all this together and make it, bring it to real life? So can you give us some examples about challenges that could come up?
Thanks, Sotiris. That's a great question. And yeah, it seems easy, but it isn't. And so many things can either go wrong or go off in the multiple steps involved in clinical trials. And given that it's a general audience, perhaps one example is the COMET trial, which is where they compared carvedilol and metoprolol on clinical outcomes in patients with NYHA class 3 to 4 heart failure. And here they found that carvedilol outperformed metoprolol in all-cause mortality with a significant p-value. But some of the subsequent criticisms, if you will, of the trial was that the drug that was used was metoprolol tartrate, which is a short-acting form, and not particularly demonstrated to have had a survival benefit, so that might have played in favor of carvedilol. And also the target dose was also lower. It was 100 milligrams per day, whereas the known target dose at the time was 200 milligrams per day for metoprolol. So whereas carvedilol was at its optimum and correct dose. So all these factors might have resulted in favor of carvedilol and a significant result. On the flip side, we have also the Cabana trial, which is a lot more recent. In this trial, they randomized patients with atrial fibrillation, a large population of atrial fibrillation patients, to either catheter ablation or a standard of care drug therapy. And this was what you would call a negative trial. I mean, there was no significant effect in favor of atrial fibrillation in the trial. And they encountered a lot of problems even during the trial process, where the primary endpoint had to be changed because there weren't enough events. And this really constitutes the importance of a good trial design and picking an outcome with sufficient events that would match your power for the trial. So the primary outcome had to be changed midway in the trial with, of course, a change to the trial protocol so that they could include a lot more events to the trial. And this was also marred by a large number of crossover rates. And we know that crossovers are never good for randomized control trials. And this trial had about over a 25% crossover rate, which again could have resulted in an underestimation of the benefit of ablation. And there were some criticisms about the analysis as well. I think that's something that can be discussed in the later webinars about intention to treat versus on-treatment analysis. So that's, yeah, let's wait for the next webinars, I suppose.
Indeed, wow, that's very well said. Very nice examples. The COMET trial showing that the drugs have their limitations and one must be very careful about how to design a trial with drugs. And the Cabana trial, a crossover problem in trials that is very common in when we're comparing drug therapy with interventions. And you know, everybody begins with the best intentions for a big trial, and then on the way there are thousands of things that may come up and may create some problems, even adjusting the primary outcome. So that is a wonderful example. Thank you very much, Aisa. I think we're very well on time. we had some questions about the concept of person year and hazard ratios. And my understanding is that this will be addressed in following webinars. And I don't think, do we have any other questions?
There was something about internal validity versus external validity. So in a nutshell, external validity in an RCTX, it represents the generalizability to a real world population, and internal validity gives us an idea about how vigorous it was conducted and how robust the data it generated. So I think in the interest of time, as Biljana said, and because we have a lot of statistics concentrated courses in the future, I will let those be dealt with in the rest of the questions rather.
Another question from the audience for Aisha Kader, and someone asks if you could explain a little bit about person year concept for computing hazard ratio in RCTs.
Would Sotiris like to take that question?
Yes, I think this is what will be covered in the future, right? But in a nutshell, the person years are used in trials that involve follow-up over time, and you have to adjust for the follow-up of the patients. And this is where the concept of hazard ratio and the difference to odds ratio comes up. And I'm pretty sure this will be a topic of the coming webinar. And at this point, I would certainly welcome you, all of you, and I would also be there myself to attend the next webinar, which I'm sure it's going to be an awesome one. So stay tuned in, and I'm sure the Pink young ladies are going to create a wonderful program for you.
Indeed, the time is almost over, so Biljana may give us the next appointment.
Okay, I will first of all would like to thank everyone who was with us today, over 130 people live, which is a big success for a first event. Again, I would like to thank IYAC for inviting me almost a year ago to participate in this, and especially Dr. Di Fusco for this amazing idea that I think that we'll bring home in the best ways possible. And without further ado, I would just like to invite you all to stay tuned for Wednesday, July 6th. It's going to be again 5:30 p.m. British Standard Time and 6:30 p.m. in the rest of Europe, except Greece, Cyprus, Portugal, which is also on BS time. So, and we will have the statistical principles and data management. It will be chaired by Professor Giuseppe Biondi-Zoccai and Professor Khalil Tamboga. The discussants will be Dr. Sarah Birkhoser and Dr. Giuseppe Cilibretti, while Dr. Camilla Calvieri will be giving a talk on choosing the correct statistical test, which is why we didn't answer the question how to pick a test and which test to use and which program to use. And Dr. Guillaume Bonnet will discuss data collection and data management systems. So again, I would like to thank the speakers, my Madam Co-Chair, and our discussants for spending this end of the day with us.
Thank you, Biljana. Just a few words to end. I want to remind that all attendees will receive an email asking for the feedback. We would appreciate if you could take a minute to complete the form, which will help us in the organization of future events. So I want to conclude, and I am very grateful to all Pink IYAC members for their valuable support. Thank you very much, and see you soon. Thank you.
Thank you.
Thank you.
Thank you. Wonderful.